Right, Beth, thank you ever so much for coming today. Absolutely was fascinated by your talk on sarcopenia and deconditioning. So could you just give us a few thoughts about how the session went and give us a bit of a summary of the key messages that us rehab folk need to know?
Yeah, sure. So I think the session went well. There was lots of questions, which is always a positive. I think as a physiologist, so not a practitioner or a medic, I think what I bring to it is the kind of the message that we need to understand why certain individuals perhaps do or don't respond to rehabilitation regimes, and actually perhaps there's certain times or certain protocols that can work best for them, and that this is evidence-based with some of the physiology work that we do in collaboration with our rehabilitation partners.
Excellent. Now you presented some very alarming stuff, particularly in relation to immobility and age-related resistance, but there were some positive messages as well there. So for us rehab folk that are charged with rehabilitating some of these immobile elderly folk after life-changing injuries, you seem to be suggesting there's emerging evidence for some of the interventions you described. Can you summarise that for us, and which direction are we headed in?
Yeah, so I think, again, it's about considering the patient or the individual and what their capability is at the time that you get to kind of access them. So I think some of the new emerging messages are things perhaps around neuromuscular electrical stimulation. So for individuals who perhaps can't do standard resistance exercise training, that's always been thought of as kind of the gold standard protocol for maintaining muscle mass. We also need to consider nutrition contractile interactions. So, you know, a contractile activity is beneficial, but if it's not supported by adequate nutrition, then it's not going to achieve its full benefit. And I think, again, there's some novel work around the timing of when we should be doing exercise in relation to periods of immobilization. So work by Lee Breen and colleagues at Birmingham showed that actually how close it is to when the immobilization starts is actually really important.
Yes, I think that's a key message. So we need to get in there as early as possible. So you talked a lot about the prehabilitation work you've done. We want to try and attract you into the rehabilitation space. The National Rehabilitation Centre obviously is a huge opportunity for us in the region, and we very much want to have our patients to have access to the research and the scientific work that you do. What do you think are the opportunities in the rehabilitation cohort of patients to try and demonstrate the efficacy of some of the work that you've done?
Yeah, so I do think that rehabilitation, of course, is equally important and actually has a much kind of longer grounding, I guess, than prehabilitation. I don't think the two necessarily need to be mutually exclusive, and I think for some patients, actually a composite package of prehabilitation before a clinical insult, if we're going to call it that, and rehabilitation afterwards is actually what's going to be best. The NRC does offer a fantastic opportunity for us both to understand and to test the efficacy of novel, we'll call them rehabilitation interventions, but you're not going to get me fully away from prehabilitation.
I tried.
I think we need to make sure that we understand how and why, where and in who interventions have most potential before we put them into a clinical setting.
Excellent. And just last question. So we're in a football stadium at the moment. As you say, quite an interactive session, and you were sort of cornered at the end of it with a lot of questions, and I suspect there may be more coming your way anyway. What are your general impressions of the conference so far?
I think it's a great conference. I think it's really nice to have diverse audience, but with a shared interest. So obviously when I asked about the kind of attendees, you know, it's medics, it's physios, it's other AHPs, it's scientists. And I think it's really good to bring all of those different people together. And I think the questions I got very much reflected that. Some people were really hot on kind of, a bit more about the mechanistic insight, and other people were like, but what about goal setting for our patients, or what about when they're back at home? And so actually I think it is really nice because, you know, these patients aren't just a patient for one of us at a set time. They're an individual with a spectrum of whenever the insult happens and then getting them home and living well. And I think that's what we all need to focus on.
Thank you very much, Beth. Thank you.